Thank you. All right. Good morning to everyone. I am glad that everybody is here. We have a good crowd coming in to join here, and I am honored to introduce our guest speaker today. We have today Dr. Karishma Parikh, and she is coming to us live from the other end of the continent in New York, where it's chilly there. Dr. Parikh is an assistant professor of pediatrics in the Division of Child Neurology and Neurodevelopmental Disabilities at Rutgers Robert Wood Johnson Medical School. And she trained in New York quite a bit, got a Bachelor of Science, Neuroscience at New York University, got her medical degree at Saba University Medical School, School of Medicine. But she would return to New York to do her pediatric residency at SUNY Downstate Medical Center, then her pediatric neurology fellowship at New York Presbyterian Weill Cornell Medical Center, and then went on to do her fellowship in pediatric neuro-oncology at Memorial Sloan Kettering. And she's now part of the multidisciplinary pediatric neuro-oncology team at Rutgers Cancer Institute of New Jersey. And Dr. Parikh actively sees children and young adults with primary brain and spinal cord tumors, neurological complications of cancer, as well as neurocutaneous disorders. Her clinical and research interests include neurotoxicities of oncological therapy, particularly those related to neurovascular disease, along with neurometabolic conditions involving receiving cellular and gene therapies. So we're very fortunate to have you speak with us today on neurological toxicities and sequelae of pediatric brain tumors. Welcome, Dr. Parikh.
Thanks so much, Dr. Lewis. Yeah, it's a pleasure to come here. So thank you so much for the kind invite and intro. Dr. Lewis and I, we were kind of talking beforehand. I mean, we fortunately have done really well with the survivorship of pediatric tumors, including brain tumors. And so this is a relevant topic. I know we have a wide audience, but we often get a lot of these consults in our inpatient and outpatient. So I'm very happy to share this together. I have no disclosures. So some of the objectives today, really to identify the most common types of pediatric brain tumors and their clinical presentations, kind of understanding that, and then how it translates into the treatment and sequelae. It's kind of an important sequence that is nice to talk about. And then identifying neurological presentations associated with pediatric brain tumor therapy. What are some of the common causes of neurotoxicity with these therapies? How do we overall manage them? And overall, what are the long-term neurological sequelae that we have to think about that we can kind of prevent in general? So I'm going to talk about pediatric CNS tumors a little bit, and then the overview of toxicities. We'll talk very briefly about some of the newer therapies that we might have heard about together as a group, and then overall, what are the long-term sequelae that we have to think about? So pediatric CNS tumors, which includes, of course, brain and spine, incidence is about 6 in 100,000 in 0 to 18-year-olds. I often do see children, just like in oncology and pediatric neurology, even neurosurgery, up to 21, sometimes up to 25. And a lot of some of our even adult patients get pediatric cancers like medulloblastoma, but in general, 6 in 100,000. We get about 4,000 new pediatric CNS tumors each year. It is the most common solid malignancy in children, with the most common being gliomas, which is pediatric low-grade gliomas, which is the most common pediatric CNS tumor. Pediatric high grades, which are 8 to 12%, which unfortunately, as we know, have a low grade, have a very high mortality rate. Medulloblastomas and ependymomas. Pediatric CNS tumors are unfortunately the most common cause of cancer-related death in children. But on an overall basis, and this is one of the reasons I do pediatric neuro-oncology, is that we really do have quite a bit of very high 5-year survival rates of 75 to 80%. And that's because we have a lot of our tumors are pediatric low-grade tumors. And because we have improved survival, we have really unique long-term sequelae for these survivors, which include endocrine, psychological, neurocognitive, and neurologic, amongst many others. We have had a new classification. It's not so new anymore. It's 4 years old, but I like to joke with the trainees that I finished my fellowship July 2021, and this new classification came out in October 2021. So basically all my what I learned in fellowship was uh, not as relevant. But there's a CNS5 which we use, and fortunately we've only gotten better at our diagnostic skills. This uses a combination of histopathologic classification, which is a more traditional classification, and now we're using a lot of biomarkers with molecular neurogenetics that helps us really personalize and better understand and prognosticate for our patients. Tumors in children typically carry a low burden of genetic aberrations. Is very different from adult populations. You look at something like a traditional GBM, even at melanomas and such, they're very have multiple genetic mutations and changes. And so for most patients in pediatric patients are driven by 1 point mutation or a fusion, often like in the low-grade tumors, for instance, too, which is helpful. Pediatric spinal cord tumors are pretty uncommon, less than 10% of the population. Brain metastases are very less frequent. We also really don't see it. We do have improved survival rates in solid tumors. So some of that is where we see some of the brain metastases and secondary tumors, but not so common compared to the adult population. And then similarly, paraneoplastic syndrome is also very uncommon. I know we always uh, look for them in autoimmune encephalitis, particularly for teratomas and such. But really, the most common paraneoplastic syndrome that we see is opsoclonus myoclonus syndrome and neuroblastoma, which actually ends up being the most common one. And outside of that, really uncommon, again, compared to the adult population. Our clinical presentation seems fairly obvious, and of course, it's going to localize to the brain or where it is in the CNS. But it's also really dependent on the age, the size, and the growth rate. The ones that tend to be slow growing, they produce massive shifts. They're larger in size. They need to really tip that point before they're symptomatic. The ones that are rapidly growing, you're going to get a very short history, and they can present at a smaller size. The higher grade tumors will also have faster onset of symptoms usually, and usually the progression of it leads to diagnosis. The less than 10-year-olds are mainly infratentorial, and you can see the diagram here, and that has to do kind of with the neurodevelopment. Less than 3 and older than 2 are mainly supratentorial, and less than 1 is very 50-50. Symptomology in infants are really nonspecific oftentimes, so they may have an increase in head circumference or change in velocity. They may be more irritable, have some behavioral regression or developmental regression, failure to thrive, and again, depends on kind of where it is. I really like this paper. It's actually from 2006. It's a retrospective study that was done in the United Kingdom for 14 years. And this really looks at, and Dr. Lewis and I were just talking about it, as a pediatric neurologist, general pediatric neurologist, we often have, headaches, primary headaches, and mostly our patients are worried about secondary causes of headaches. And this study just basically says that headache almost never really presents as the isolating sign, isolating symptom for a primary brain tumor. And so you can see it here as the first symptom at the same time, 41%. And then percentage rates of associated symptoms in children with headache with a brain tumor, and this is time stamped less than 4 months and greater than 4 months, almost never just headache alone. There's always other kind of symptoms, whether it's on the exam or other kind of clinical history. So you can see the range of clinical symptoms that they have. And then even if you're looking at abnormal neurological signs, there's always something, cranial nerve abnormalities, cerebellar signs, papilledema, et cetera. So I think we have to kind of keep this in mind. And we often do. That's why we look at red flag symptoms and kind of focality on the exam before we worry about and/or scan. So this is a nice table from Continuum from a couple of years ago, just highlighting the localization within the brain and kind of the symptoms and the brain tumors you find with it. Like I said, it's age dependent and then symptomology dependent. Kind of understanding which age it is, where it is, kind of gives you an idea when you're looking on MRI what it could be. So optic pathway gliomas or pilocytic astrocytomas, we often see that in NF patients. If you're looking at the thalamus, you're going to see some of these higher grade diffuse midline gliomas, which are, the former kind of DIPG and all of that nomenclature. Germ cell tumors are supercellular. Posterior fossa, very common in younger children. You often see medioblastoma, pilocytic astrocytoma, and ependymoma. That's kind of what we see most. Brainstem, you have kind of the high-grade gliomas predominantly, but we also see a lot of low-grade gliomas in that area. and so on and so forth. The other thing to keep in mind is oftentimes we may come get a consult inpatient about a neurological emergency. And so both direct and indirect effects of CNS tumors could be the presentation we are confronted with. So obviously, increased intracranial pressure, seizures, encephalopathy could be the initial presentation of a CNS tumor, depending on where it is. And then treatment-related effects we might see after the fact, methotrexate toxicity, PRES, endocrinopathies, and paraneoplastic or autoimmune conditions, which, like I said, is not so common. This is on a little bit older end of a chart, pie chart, but it still kind of talks about pediatric CNS tumors, both in terms of where it's located and what type of tumors that we have. I kind of gave the breakdown before, but this is from 0 to 19 years age. Adolescents tend to have more germ cell tumors. Younger children have a lot more of the embryonal tumors, which are pineoblastoma, medulloblastoma, ATRT, ETMR. Adolescents may have kind of a mix of both low-grade tumors, like optic pathway gliomas, and then the classification kind of keeps going. And you can see a lot of the pituitary craniopharyngeal ducts have a lot of the percentage, along with cerebellum. Brainstem can be both low-grade and high-grade tumors, and you can kind of take it from there. Pilocytic, and like I said, a lot of the low-grade tumors are fortunately the most common CNS tumor, and out of which after that would be ependymomas and medulloblastomas. I just wanted to talk about low-grade gliomas, pediatric low-grade gliomas for just 1 second, because they really are often found and common. Sometimes they may even present as an incidentaloma when we're doing these MRIs for another indication. Fortunately, 20-year overall survival is almost 90%. There is some variability because now, we have a better classification of these tumors, so we're kind of understanding their markers of um, how they're doing. But the nice thing is we consider these kind of like a chronic illness. There's a lot of morbidity associated with them, and that's why we have this progression-free survival, which means the time for it to recur. In their natural history, they often do recur or could progress. We often try not to really treat them outside of, if you can do a gross total resection, that's kind of the primary treatment modality that we like to. If they've had a subtotal resection, if they have clinical progression or radiographic progression, that's kind of when we think about treating them. And then obviously with multiple modes of therapy, depending on where they are, for instance, if it's an optic pathway glioma, you can imagine that they could have changes in their vision, they could have endocrine dysfunction, et cetera, et cetera. Overall, a lot of our clinical trials for all of these pediatric brain tumors is kind of looking at how do we optimize outcomes and optimize quality of life, particularly for these low-grade gliomas. If you do have a tumor predisposition syndrome like NF1, you're predisposed to optic pathway gliomas, which are pilocytic astrocytomas, or SEGAs with tuberous sclerosis. Outside of pediatric low-grade gliomas, the treatment that we use is really dependent on the treatment type. We always try to do a gross total resection when we're able to. It's not only diagnostic, but it's therapeutic, of course. If it's a more high-grade glioma, these diffuse midline gliomas, we do radiation therapy. We also do radiation therapy for medulloblastoma, which can seed through the CNS. We try to favor protons when we're able to. There's less scatter, less secondary malignancies, and less systematic effects. And photons, unfortunately, we do have to use them for more of the aggressive tumors. Chemotherapy, it really depends on what type of tumor it is. Something like an ependymoma will just need a resection and radiation. Something like medulloblastoma will need a resection, radiation, and chemotherapy. These are some of the newer therapies that we're using, like immunotherapies, and we also have clinical trials. Anti-angiogenic therapies, which is bevacizumab or Avastin, we kind of use it for recurrent or progressive second, third, fourth line for low grades, but we also use them for radiation necrosis and some of the higher grade gliomas. So neurotoxicity, let me kind of start talking about that because that's what the Grand Rounds is about. We have limited pediatric data, of course, like many things in pediatrics, because fortunately we don't have a large number of patients. But I think with time we're going to understand this way more, and there is a lot of pull to understand this as we have improved childhood cancer survival rates. Oftentimes, like I kind of alluded to, we have multimodal therapy. So as a result of from surgery, chemotherapy, radiation, et cetera, you can imagine that they're both direct and long-term sequelae and toxicities that can develop. The pediatric cancer survivors in general have a broad neurological morbidity. So I'm going to focus more on pediatric CNS tumor patients, but if you think about our leukemia patients, you think about other kind of solid tumor sarcoma patients, they really get a broad range of chemotherapy and management that have quite a bit of neurotoxicities. A lot of formerly we used to use the PEG asparaginase that, for instance, gives it's prothrombotic. We get sinus venous thrombosis from that. So that's kind of the common things that we've thought about and gotten consults for, but now it's going to only broaden. Clinical trials are really meant to improve survival and long-term sequelae and toxicity. We're really looking at the optimal doses and treatment regimens. And neurotoxicity syndromes, they can present both acutely, subacutely, and long-term. It involves both the CNS and the peripheral nervous system. You can have eight, late, or combination, like I mentioned. Oftentimes, they can be idiosyncratic, meaning it's personalized to the patient. Um, every single person who receives, let's say, vincristine or Avastin is not going to have the same symptomology or even the same side effects. We have averages, but obviously everyone is really variable. It's going to depend also on the combination of therapies they got, what their overall clinical baseline is. Do they have any other underlying conditions or comorbidities? What are their kind of neurological deficits going into therapy, kind of going into surgery, and also what is their overall treatment profile? Commonly used CNS chemotherapy. So, like I said, I'm going to focus on the ones we use for CNS tumors. Is vincristine, vinblastine, carboplatin, cyclophosphamide, cisplatin, etoposide, and temozolomide. The most common neurotoxicity that we see from chemotherapy is peripheral neuropathy, but as we might have all seen, we do things like encephalopathy and seizures, which can be isolated or together with something like PRES. Very rarely you can see cerebellar degeneration or ototoxicity, and et cetera. It depends on the type of chemotherapy drug that we're using, for instance, as it relates to chemotherapy. What's the cumulative dose? What's the duration of the dose? What's the administration? We have differences in methotrexate toxicity, and we do see methotrexate-related vasculopathies or kind of stroke-like symptoms, oftentimes because it is intrathecal versus systemic administration. And then what part of the CNS or peripheral nerve system was really affected? So to kind of give a profile of this, if you look at encephalopathy, for instance, these are some of the agents that can cause it. And then depending on what the presentation is and what the risk benefit of either altering therapy and or what the next treatment plan is, you may discontinue it if you can, or you may give supportive therapy. Aseptic meningitis, seizures. Seizures are complicated, which I'll show a table in a second, because there's so many etiologies of seizures. Is it because of a metabolic derangement? Is it because of the chemotherapy itself? Is it the chemotherapy agent cause a metabolic derangement? Is it a surgical kind of gliosis from the surgery, et cetera, et cetera? Stroke, PRES, PRES has a long list of etiologies, myelopathy, GBS, et cetera. So this is PRES, posterior reversible encephalopathy syndrome. As we know, it doesn't always have to be posterior. It oftentimes is reversible and oftentimes can present with headache, seizures, visual changes, and encephalopathy. Oftentimes it's supportive. Many of the consults is kind of a risk-benefit discussion with the primary oncology team, particularly if it's a patient who's getting therapy for leukemia. Very commonly in the initial cycles, induction and maintenance PRES is common. Blood pressure control. Oftentimes, I do start anti-epileptics, anti-seizure medications, and then depending on their recovery, repeat MRIs, repeat EEGs, discontinue it, provided that everything else has been kind of stable. Radiation therapy, we both see acute, early delayed, and late delayed complications. Um, Oftentimes, the symptoms that a patient may have presented with at the time of finding their tumor, based on that, you can have worsening of their or deficits and or symptoms with radiation because of the edema. Seizures can get worse, so I often do not change or wean off their anti-seizure medications during that time. Headaches, patients may be on dexamethasone or some sort of steroid during that time, which I also try not to change because some of these things do get worse. Radiation somnolence syndrome is a very interesting side effect I've seen a couple of times. Really, a patient is doing quite well, and then 4 to 6 weeks, 6 to 8 weeks, kind of after getting radiation, they're extremely tired. I had a patient who his mom called and said he's just sleeping all the time. He falls asleep like in his cereal, kind of what's going on. And it's kind of an expected phenomenon, it doesn't happen all the time. So we ended up giving him kind of low dose steroids for a short period of time and he kind of perked up. Very interesting phenomena, but it is self-limiting. Steroids help a little bit with that. And then some of the late delayed complications, and one of the reasons we are again using protons versus photons, the risk of secondary tumors in proton radiation therapy is much higher. But with radiation, you can get vascular abnormalities. Radiation includes vasculopathies like moya-moya, arteriopathies, SMART syndrome, which is also a very unique syndrome. You get stroke-like migraine attacks after radiation therapy. It feels like a complicated migraine and a methotrexate toxicity without um, with the history of radiation effectively. Neurocognitive function is a big thing. We try to get baseline neuropsych testing when we're able to, and follow up neuropsych testing when we're able to. Sometimes in some of our patients who have an underlying learning disorder and or dyslexia or inattention ADHD, things may be a little bit more complicated. So try to get baseline and then follow up. This is kind of what I was alluding to before about seizures in cancer patients. You can see that conditions that provoke seizures is quite multifactorial. A patient may have seizures because of the brain tumor, maybe possible of a progression or metastases in adults. The edema or post-op kind of complications, post-op stroke, for instance. They may have an underlying seizure disorder. They may be neutropenic from some of their chemotherapy and as a result got an infection. They may have electrolyte or metabolic dysfunction because of the chemotherapy they're getting, et cetera, et cetera. So you can see that on every level, we have to kind of make these considerations. There might also be drug-to-drug interactions. Maybe they're not metabolizing their anti-epileptics well, et cetera. Fortunately, we have really changed a lot of our therapy and we're getting better at diagnostics, as I mentioned. So we are using a lot of targeted molecular therapy because we do understand these single driver mutations in a lot of our brain tumors, particularly the low grades. And then we do understand that these target therapies do have less kind of systemic toxicities overall. It's easier to administer and have quite a bit good profile in terms of responsiveness. So this is kind of just an example schematic of kind of understanding that we use MEK inhibitors for some of our low-grade tumors. They originally came out for kind of our NF1 patients for inoperable plexiform neurofibroma, so selumetinib. We're also using BRAF inhibitors, RAS inhibitors, ERK as well. And the combination of it for different types of tumors has been for both primary and secondary kind of types of treatment has been quite remarkable. Um, there are a bunch of clinical trials understanding the profiles and the effectiveness of using these in different tumor types, both with traditional chemotherapy and uh, overall effectiveness and progression-free survival. These are just kind of some of the side effects that we see systemic. You can get fatigue, acneiform dermatitis, which is way more in MEK inhibitors and BRAF inhibitors together. They seem to have less cardiovascular dysfunction, nausea, vomiting. That's a little bit more initial, and then more complicated things like retinal detachment, which I have heard about one or two times, and that's pretty much it. Really, no neurotoxicities per se that have been described. This paper came out, the study came out 2 years ago, or a year and a half ago, really remarkable, um, showing that patients who had a pediatric glioma with a BRAF V600E mutation, when using dabrafenib, which is a BRAF inhibitor, and trametinib, which is a MEK inhibitor, the combination of those had overall better responses, uh, less toxicities, and overall better progression-free survival compared to traditional chemotherapy. So this was really remarkable and has changed the way we think about these type of patients. So you can see here that 47% compared to 11% with traditional chemotherapy, clinical benefit in 86% of the patients, and they had, whoops, sorry, 20 versus 7.5 months for the progression-free survival. And really, the grade 3 and adverse reactions were more common in the traditional chemotherapy patients compared to the targeted therapy. Another therapy I kind of mentioned is bevacizumab or Avastin, which we have used in recurrent optic pathway gliomas, sorry, has shown benefit in visual outcomes. We do use it in some of our higher grade gliomas. This was a nice paper that came out a few years ago looking at the differences of neurotoxicities that are unique to pediatric population versus adults. And so because it's an anti-VEGF, a lot of the complications include increased bleeding risk, pulmonary embolism, and specifically for neurotoxicity, neurovascular complications, press, seizures, and other kind of thromboembolic events. Other things that were seen in pediatric population was pain, neuropathy, press in 6%, and seizures in 6%. We've also been using a lot of immunotherapy and trying to apply it to the CNS. The original thought was that the CNS is, a microenvironment, has a unique immune system, so it's not as impenetrable as we usually thought it was going to be, but it is quite different than the rest of the body, fortunately. So trying to address some of the tumor heterogeneity, we're using immune checkpoint inhibitors like immune therapies like checkpoint inhibitors, adoptive immunotherapy, vaccine trials, and really it's been quite monumental. The challenges have been, the antigen escape, kind of understanding what are the specific antigens that we're targeting. You get a lot of different types of side effects that are kind of immune system modulated, and kind of understanding the response to these tumors is a little bit complicated. We're also using vaccine oncolytic viruses as well. This is kind of another schematic that explains the areas that we're trying to target in immunotherapy. So, we're looking at the T cell. How do you prime it for the right antigen? How do you present the tumor antigen to kind of change the exposure to kind of take it up? How do you prevent tumor cell death? There are a lot of escape mechanisms by the tumor. So how do you change those mechanisms? How do you suppress cytokines? And how do you optimize this T cell recognition of these tumor cells? So just historically, 2018, Nobel Prize in Medicine was awarded to two cancer immunotherapies, really has changed adult medicine, adult cancer treatment significantly. And a lot of those over the last 10 years, 5 to 10 years, we've been trying to apply it to the pediatric population. Nivolumab, ipilimumab, they're all pembrolizumab. We're using it both in and off clinical trials at different points for different types of brain tumors and pediatric tumors in different capacities. Additionally, this is kind of another schematic to kind of understand how generally a tumor will remove its antigen presenting cell and its competitiveness. And so it basically interferes with those inhibiting signals, a double negative, to kind of make sure that they're seen for the immune system. The immune-related adversary events, these are the ones that, we should kind of concentrate on and kind of understanding based on what a patient may receive is the result of overshooting the T cell activation. So the more immune positive systems within the body are the ones that are going to have more dramatic responses. So that's going to be skin, GI, endocrine are going to be more significant than the neurological adverse reactions. But obviously, the neurological immune-related adverse events are going to be way more significant, and there's going to be a higher mortality rate as a result of it. They're kind of grouped into four mechanistic categories. Is it the result of the direct targeting of the CNS because of the immune dysregulation? Is it the off-tumor or on-target toxicity? Is it related to pseudoprogression? So this is a problem that we often have because is the immune response that we get when we're looking at an MRI, is it because of pseudoprogression or is it true frank progression of the disease when we're kind of comparing the responsiveness? And then neurological symptoms related to systemic inflammatory states. So some of the unique presentations that you get with immune-related responses are PML, iris, pseudoprogression. Like I said, you see these enhancing components in T2 flare changes. I cannot say this, hypophysis, sorry. But anyways, pituitary-related complications, thickening and enhancement of the infundibulum with diffuse enlargement of pituitary glands. So oftentimes we get that inflammation and it adds to this kind of um, endocrinopathy mixed picture. Encephalopathy, altered mental status, our favorite consult, but it has, it can be acute, it can be chronic, and it's fairly diffuse and it's quite multifactorial as we've been talking about. So these are the kind of the more unique presentations of what we may see with the immune response. Um, Other medications that have been improved, I kind of mentioned some of them, like the ipilimumab, the nivolumab, and the pembrolizumab, can have these kind of arthralgia, ataxia, headaches, hemiparesis, meningoencephalitis. So you can see that they're quite diverse in terms of symptomology, varying between headaches to even a stroke-like or a tremor-like symptomology. CAR T really has come such a long way in leukemia patients and other pediatric cancers. And now we're trying to implement that into CNS tumors and brain tumors. And so what we're basically doing is we're doing a combined antigen binding T cell for one receptor. So you're basically engineering a patient's T cells to have a new target. And you can see this here. So you're isolating the T cells, you're inserting the CAR T, and then you're kind of re-injecting it to the patient system to let it do what it needs to do. It's usually ideal when we have a target, of course, and an antigen. So you want to use it for tumors like maximally expressed on tumor cells, like B7H3, HER2, EGFR, et cetera. And then the combination of using CAR T with other chemotherapy as a supplement really allows for optimization of this treatment response. So using it with chemotherapy, immunotherapy, radiation therapy, it kind of helps with that immune escape and that microenvironment that I was talking about briefly. CAR T cell neurotoxicity, we do see it often, and I don't know what the mechanism or kind of the algorithm is at your hospital. We're working on that here at Rutgers, and when I was at Sloan Kettering, as part of the neurology consult, we did have baseline exams that we tried to promote for patients before, during, and after getting CAR T. Neurotoxicity has to really be monitored very quickly. You can get encephalopathy, deficits, and seizures. Most of our patients were on Keppra, at least for a week. And you can see here that there are some cytokines that have been identified when you're presenting with these neurotoxicities and how they're kind of elevated during that time. This is a little bit older study. There are kind of newer studies looking at CAR T as well. The important part of neurotoxicity is really our pediatric patient evaluation. So the timeline is really important. The comorbidities are really important. Which is the treatment profile is very important. So you really have to have a high degree of clinical suspicion for the acute neurological change. In some cases, it may be nuanced, but and it's going to be multifactorial. But the timeline of administration helps to kind of put it through. You're going to do a baseline neurological exam. Like I said, there are some standard scores and guidelines, like ICANS, which I'll talk about in a second, for our immunotherapy-related neurotoxicity complications. We do use, the CAPD delirium score or ICE to kind of get a sense of how do we assess these patients in a little bit more standardized and objective way. So ICANS grading, I apologize, sorry, looks at the ICE score or CAPD score for patients. ICE and CAPD are a little bit inverse. So you can see if we think about the CAPD score, what is the interactivity that's been done for the patient who's less than 12, and how interactive they are, how they're able to respond. What's their level of consciousness? If they're having a seizure, they automatically are grade 3 or grade 4. Any sort of motor weakness, grade 4 automatically. Elevated ICP or increased intracranial pressure, depending on how much, is also 3 or 4. And that really gives you how severe the grading or the toxicity for immune-related toxicities is for patients. Um, and of course, you have to make sure that the consciousness is not attributable to anything else, any other medications, et cetera. And then lastly, I know I went through many things quite quickly, and in a kind of cursory way, just to cover all my bases and all of our bases. The last part of it is really the long-term sequelae. And so we have, this is from 23, I think there's a new one coming out, the survivorship guidelines from the Children's Oncology Group about pediatric brain tumors. So we have a light clinic here. We had a long-term clinic at MSK. Most centers have a group dedicated to thinking about the long-term sequelae for pediatric patients who have long-term survival and the type of treatment that they've got. So brain tumors in general, we have to think about neurocognitive, neuroendocrine, their reproductive health, metabolic, cardiovascular, secondary tumors, and then overall socioeconomic impacts. We have, like I've said, tried to really optimize our treatment regimens to prevent these morbidities, and overall survival. How do we think about it? So the diagnostic, the characterization has really helped with all of that. And there are different groups, both nationally and internationally, like the Children's Oncology Group, Dutch Childhood Oncology Group, and UK, that have different guidelines that help us think about that. This is an example of what we use for pediatric brain tumors. So what the exposure is, what are the potential long-term issues, and then what do we think about it? So you can see here the breadth of complications and long-term sequelae that we have to worry about, fatigue, sleep problems, deficits based on localization. Do they have, if they've had surgery in itself, they may have, depending on the location, have hypothalamic obesity, for instance, metabolic syndrome, radiation causes neurocognitive deficits. Apologies. We talked about secondary malignancies, cerebrovascular complications, etc. And these are some of the chemotherapies that we talk about, looking at long-term complications, cyclophosphamide, particularly for reproductive causes, in reduction in spermatogenesis and reduced ovarian reserves. Cisplatin, we usually do audiograms because there is a high risk of autotoxicity, particularly high frequency. So we monitor at baseline and kind of throughout therapy. Again, trying to monitor it and minimize it as much as we can. The pediatric CNS tumor survivors need lifelong risk-adapted follow-up care. We talked about some of the guidelines that puts all of these things into context. Clinical trials, as I've mentioned now multiple times, really are aimed at de-escalation of these treatments when we're able to. And our hope is, with the advent of understanding of these molecular therapy, molecular mechanisms and genetics, neurogenetics, we can really precisely and personalize, provide care and prognostication for many of our patients. And so neurotoxicities can be very rare to very common. Many are idiosyncratic. Many of them may not be severe, but of course can also present as a neurological emergency. Most patients receive multimodal care, so you have to kind of think that in context, both result of the individual's comorbidities and also the combined therapy effect. Neurological oncological emergencies are rare, but they can be reversible if promptly diagnosed. Thankfully, we do have improved survival rates. But that has only added to us being a little bit more thoughtful about how do we think about their morbidity profiles and prevent it. And that's pretty much it. Thank you so much. I always want to thank our patients and their families. A lot of what we learn is from their experience and the treatment that they receive and how we can learn from them. Because, like I said, many patients are idiosyncratic. So my knowledge is really based on all of our patients and what I learned from them and my mentors and colleagues, including Dr. Yasmin Kaku, who actually helped put me in contact with Dr. Lewis. She's one of my many mentors that has taught me a lot. So thank you so much. I'm happy to take any questions if we have some time. And feel free to always reach out to me if you have any questions, if you have an interesting patient, happy to learn more and collaborate.
Thank you very much. That was fabulous and you know, high intensity. I appreciated that. A lot to talk about, Karishma. Thank you.
Yeah, sorry, rapid fire, but thank you.
No, I like it. It's good. I mean, there may be some questions from people here, so hopefully we can open it up to that. I appreciate your thorough update on those, especially for those of us who don't see kids with tumors daily. But I think understanding all the short-term, medium-term, and long-term issues with that, especially as you know, I do headaches. Some of these families coming in. I appreciate your comments on the importance of the red flags for headaches and the reminder that headaches themselves are very rarely the only symptom of the brain tumor.
Hmm.
But then also just the reminder of like the rare syndromes like SMART. I know you said that happened with the stroke-like migraine attacks. I don't know if you have more to say on that in terms of how often you've seen that in the pediatric population. Because I think about it, it can be 10 years out, and so it may be, and a lot of adult neurologists really need to know that more. But in
Hmm.
pediatrics, have you seen it younger and earlier?
I've seen it once, and that was kind of a diagnosis of exclusion. And I think I've heard about it one or two times besides that. It really is a diagnosis of exclusion. I mean, it really presents, just like with complicated migraines, you have to rule out the stroke first. Similarly to this, you're going to rule out stroke, you're going to rule out migraines. If they have a migraine history, it's a little bit easier to think about. And if they have a radiation history, then you just put it together. I think that's kind of how it is. But I've honestly only seen it once, and it's even then it was like, okay, I think this is smart. It's very rare. It's quite rare, actually. In most cases, the treatment doesn't change much. It's more of the identification that the patient may be at risk of that.
Right. Yeah, makes sense. And it may be something that people may not be recognizing that are putting it together, especially if it's 10 years or longer after the
Hmm.
radiation. So it's something to think about. And
Hmm.
just the personalized nature of this, I think, is going to be so much more
Hmm.
interesting to follow through. Like you said, you're finding better treatments, and therefore the survival is longer, but then there can be longer term sequelae that are showing up that we didn't see before because the survival wasn't there. So
Exactly. Yeah.
thank you.
Yeah, of course.
Yeah, hi. My name's Jay Houtman. First, I'd like to say that I am personally thrilled to see Rutgers here in Phoenix. I went to medical school before it was called Rutgers at New Jersey Medical School in Newark, so that's great. So I actually have a question that has nothing to do with your talk was great, loved it. But I have a
Oh,
question,
thanks.
nothing to do with your talk, because I am genuinely curious. As a neurologist with neuro-oncology training, that's sort of becoming a new niche crossover between neurology and peds hemonc. And I came from Seattle where Amy Sato sort of sat in that hybrid role. And watching her progress throughout her career, I have found that that's an interesting, sort of field to collaborate in, right? Because there's certainly some overlap. There's certainly some differences in expertise. Can you take us a little bit through your journey of, kind of how you have built your career? And for those of us who are in the audience who might want to do what you're doing, our trainees, can you kind of tell us what your challenges were and like how you overcame them? I'd love to hear that.
Oh no, thanks so much. That's a great question. And to be honest, I feel like I'm not in my career. I've only been doing this for 3.5 years, but no, thank you. That's very kind. And it is quite a challenge. It is an interesting position to kind of straddle and unique expertise, which we all need. So I did pediatric neurology, of course, and thankfully because of my exposure to Memorial Sloan Kettering throughout my training in pediatrics, adult neurology time, and pediatric neurology time. I really did have quite a bit of exposure, which is quite unique to for many trainees, because many people don't have that experience kind of across the street, down the street. Um, as a practicing pediatric neuro-oncologist, it really depends on your colleagues. I feel fortunate that I'm at the Cancer Institute in New Jersey. A lot of centers do not have cancer institutes. And so straddling and finding a balance between the type of patients you want to see, and how you can help your hem-onc colleagues and vice versa is a challenge that I continue to have discussions about with my team. The unique part of neuro-trained neuro-oncology, and also onc-trained neuro-oncology, we have different expertise and skill sets. Obviously, we're much better at looking at imaging, localizing, kind of thinking about neurological complications. Some of these subtleties in exams with these complications is a little bit more of our realm. It also kind of depends on the time that you've done training. So a lot of my colleagues may not be as comfortable with some of the targeted therapies as I might be, because that's kind of what I learned in training. They may be way more comfortable with traditional chemotherapies because that's a lot of their training and how they're using it. Um, a lot of neurology trained neuro-oncologists, depending on where they're at, may think about what they want to see, what type of patients they want to see, and what their interaction in a multidisciplinary clinic may be. Often, neurology trained neuro-oncologists are way more comfortable, obviously, with NF1 patients, and using, not only the surveillance, but thinking about brain tumors in them, both low and high grade, using targeted therapies for them and such. The onc trained neuro-oncologists, or even traditional hem-onc practitioners who might have not done the formal neuro-oncology training, they may not be as comfortable with that and targeted therapy, but they may be the ones seeing the medulloblastomas that involve way more intensive chemotherapy. They may be seeing more traditional solid tumors, and a lot of neurologists may be seeing more of the low grades, the follow-ups, doing the follow-up scans for some of these incidental findings we may find. A lot of what I do also is I help our endocrine colleagues. They often have, they do a lot of scans for pre and post growth hormone. So kind of understanding and helping them kind of see what's relevant on imaging, whether it needs follow-up, if it's clinically necessary for treatment or not, or follow-up. I do a lot of that. So it's really center dependent. And I think I'm still trying to figure out my role here and vice versa. And a lot of, I think, neurology trained neuro-oncologists, depending on the setup and what's been set up for them, see variations of that. And it's evolving, which is the nice thing about it. I don't know if that was helpful, but
No,
and I'm happy for any trainees if they want to reach out. I'm happy to talk more about that.
yeah, no, it's very helpful. I will tell you, Karishma, I'm a neurosurgeon, so I know nothing about the struggles that you described, but we have our own set of struggles, but not those. Um, but everything you're saying is exactly what Amy probably would have answered the question the same exact way. And so the suggestion actually I have in thinking about it is you guys should really organize the neurologist trained neuro-oncologists. You guys should create some sort of a network consortium because I think you all have very similar struggles. Like, where is the Venn diagram between heme and neurology? Where do I sit in it? Do I show up and they say, well, you can see all the NF, or you can, sort of follow all the non-operative low-grade glial tumors or whatever it is, and have seizures or have headache or something like that. Whereas maybe you're like, well, I kind of want to see medulla and I kind of want to see ependymoma.
Hmm.
And so I'd be really, that would just be my own 2 cents on it. And for anybody
Yeah,
else,
no, that
all this
It's a
out.
great idea, and I think Dr. Kaku and a lot of the more a little bit more senior neuro-oncologists at our meetings, we have been trying to do that when we can. And I actually it's a good reminder for me to follow up on that. And I think every center is different. I went to the most recent Child Neurology Society meeting, and I was asking Dr. Packer kind of how to navigate this. And oftentimes there is a little bit of resistance, like, oh, you're a neurologist, and I'm like, most of the chemotherapy regimens we use are Dr. Packer's, so who's a neurologist. So it is really center dependent, but it is a good thought, and I think we should talk about our challenges, but also the things that work well with our colleagues and with each other. So yeah, thank you for that, Jay.
Yeah, sure, no problem. And I know Dr. Friedman has an extensive decades of experience sort of straddling both realms. I was just kind of curious if he had any thoughts there.
Hmm.
No, I would just make the point that the early neuro-oncology days was actually sort of pioneered by the likes of Roger Packer, Bruce Cohen, and a lot of others. And so the changes that have taken place within neuro-oncology over the years has sort of been an interesting phenomenon. And it is tends to be split depending on the nature of the disease presentation. Neuro-oncologists tend to do well just focusing in on the tumor itself when it comes to things like NF or other P10s or other disease-associated tumor predispositions. Neurology, I think, is better adequately trained at managing the entire patient, not just the component. Most protocols are now, most treatments are now protocol driven, and so I think the earlier point made by Dr. Parikh about neurology being able to provide a more general overview, including examinations and looking over the scans, not just relying on radiology reports, I think is still a differentiating factor. So.
Yeah, and like you said, Dr. Friedman, I think we they're just different skill sets. And some things that I often may not think about. I fortunately my oncology colleagues do, and vice versa. So it is a interesting thinking about how our skill sets are very different. The other thing I recently learned, which might resonate with most of you, I think, is that in neurology we're a little bit more comfortable with diagnostic uncertainty. We've had a couple of patients, the pathology was uncertain, and I felt very comfortable with, okay, let's just follow, let's see what happens. And my oncology colleagues were like, no, we need to know what it is. And I'm like, but we don't. It's okay. We will figure it out. So I think in neurology we've also been a little bit more comfortable with waiting for that clinical presentation to become somewhat relevant at times.
I think a lot of the pioneering work outside of just straight chemotherapy, like high frequency ultrasound, Roger and others have been instrumental in pioneering alternate options, and so I think there's a place for both. I think it's a symbiotic relationship. They're much more familiar with the chemo in general because they're using it all around multiple occasions, and so tend to be better prepared at typically using the chemo. But I think some of the innovative stuff outside of direct chemo has come through a lot of the neurology with gene therapy, for example. Again,
Mhm.
neurology leads the way in that. So.
Absolutely. Thank you so much.
Well, I appreciate all the time and all the effort you put into this. Thank you for presenting. I'm looking in the chat. I don't think we have any other questions in the chat. So if anybody else has any other questions, they can unmute and feel free to utilize the expertise of our guest here. Otherwise, we can end up getting back to our regularly scheduled Mondays.
Sounds good. Thank you so much, Dr. Lewis, and thank you all for listening. And like I said, if anything pops up now or in the future, happy to always collaborate. It's fun to think and learn from different patients all around the country and world. So thank you again. I appreciate it.
We appreciate you very much. Thank you for coming, and stay warm out there in New York.
Yeah,
Oof,
thanks.
New Jersey.
Thank you.
Keep
Bye.
it good. Take care.